My name is Chris Jagmin. I'm a family physician and a Texan, so being up here in the wintertime is a little tough for me. I brought every piece of cold clothing I could find. I have a variety of hats I wear, and I'll try and explain where I'm coming from today. So I'm an executive director for Aetna, CVS healthcare company. And in that role, I'm head of medical policy for the organization, which involves mostly payment and coding policy and a few other things. Some of my sidelights, including being a vice chair of the AMA CPT Editorial Panel, and I've also been a member of the joint CPT RUC Workgroup on E&M services and their development. So today I'm here speaking on behalf of the CPT editorial process, and I'll offer comments and opinions today, some of which I'll impact on commercial insurers, but I do those not as a representative of CVS, so that's my disclaimer today. We're kind of fortunate in that we have a year to consider what's going to happen here. And we even have some opportunity to correct some things on the fly. So we had a lot of really accomplished, smart people sit around and create a bunch of great codes, and now we have to hit reality. They're going to be used. And every time that happens, we find unintended consequences. So we would love to hear feedback today. We would love to hear your comments. We'd love to say, this is an area that needs shoring up, or did you think about this, or are you really going to do that? You know, we get some of that, and it all helps very much in the process. Any questions or comments before we get started into the material? All right, well, my first comment overall on this is that this was a process that was driven largely by CMS and impacting Medicare membership. But as a commercial insurer, if you think about what's happening here, it's going to impact commercial finances differently. And I would urge you all to be raising these issues inside your organization early on, as I've done inside of mine, because when you start looking at commercial distribution of E&M services, it's markedly different than Medicare, and it will impact organizations differently. It will impact contracting strategies. It will impact utilization issues. So I've tried to raise those in my own organization to people who don't know about codes, who don't know about billing codes, but who are finance actuarial type folks, just saying, hey, something big is coming down the pike here. So the history, we'll go through the history of this, how we got to where we are today. We'll talk about the different revisions and where they're impacting and where they're not. We'll talk about the RUC recommendations, and we'll talk about where we plan to educate and how we plan to move forward. So where did we get there? How did this happen? If you remember, we've been debating E&M revisions for a decade, right? And we've still got the 95, the 97 guidelines to use. We've tried over the years at the panel to update things. For various reasons, that didn't go very far, even when we had some work product to finish. So what happened? So in the initial proposal put out for the CMS final rule, released in 2018, the goal was administrative simplification. And CMS perceived, at least, that the current E&M codes were outdated based on comments and letters. So if you've read the Federal Register over the years and you've seen the comments that come in from various quarters, not just physician groups, but it could be insurers and others, and saying, look, the E&M structure seems to be outdated. It's more and more difficult to adjudicate. Insurers are having tough times. Auditors are having tough times. Physicians are having tough times submitting claims and getting them paid. So perhaps there's something can happen here to make life easier. And in the advent of the EHR also, now we have pages and pages of documentation to wade through for a simple E&M visit if you're an auditor. So the goal in the medical necessity, in their initial proposal again, was to eliminate the requirement to document the medical necessity of furnishing visits in the home rather than the office. That was fine, relatively minor thing unless you're doing that, in which case it's major to you not to have that burden anymore. Eliminating the prohibition on same-day E&M visits billed by physicians in the same group or the same tax ID or medical specialty. That's been a bugaboo over the years, and particularly in the commercial space, because the way large medical groups are organized, you may or may not have good TIN and PIN identifications on those members, on those physicians. And what looks like one member getting 2 E&Ms from a same physician on the same date of service is really different. They're really 2 different docs. I don't know how different organizations have dealt with it. It continues to be an issue in my organization, just getting that level of detail on physician structure, particularly as physicians more and more are employed by large organizations. The documentation of level 2 necessity for an office E&M is sufficient. So the initial proposal was to collapse the levels of E&M services, and that middle tier would be from what was currently a 99212, 13, and 14, would just, all you would need to meet would be the 12. That did not occur, so I'm not going to comment much more about that. Documentation redundancy. This is a big issue. So if you think about the audits that go on today, if you're looking at a 99215 or 214, and you're looking for that review of systems, you're looking for that history. You've got all these scoring tools that say, okay, you get a point here, you get 2 of these, you get 5 of these, and it totals up to say, yeah, you've met that documentation standard for that part of it, right? Well, here's a real advance forward, I think. That's being eliminated in the new proposal for the existing office visit codes. So you don't have to go back and redocument the things you've documented before. Staff can help you with that, and all you have to do is confirm that you reviewed it and you feel it's accurate. So I think just from a documentation viewpoint, from a practicing physician, that is going to be helpful. So again, we're talking about the initial proposal. So simplify the code level selection, and initially the proposal was that physicians could pick and choose how to document. So you could continue on the way things are currently, or you could choose to document based on medical decision-making only. Very different construct, or just face-to-face time. So the initial proposal had 3 different ways of going about documenting the same service, and different physicians and different specialties and different groups might choose different ways of doing things. There also was a proposal to eliminate payment differentials between services by collapsing the codes. So this caused a stir, as you might imagine. So essentially the proposal tied not only to simplification, but also now reimbursement changes. So the proposal essentially was to collapse the level 2 through double 5s into one blended payment rate. Now, depending on where you stand as a specialty, you either loved this or hated this, right? So if you bill a lot of 99212s and even 99213s, but you would get paid for a 99214 or 5 or some blended rate in between, you said, this is not a bad thing, right? But if you're a busy oncology practice seeing a lot of sick patients and you're doing 99214s and 15s, you're going, no, wait a minute. I don't have a lot of brief visits to bring my payment level back up. So this is unfair to me. And so I think CMS, to their credit, thought through this and said, okay, let's look at the distribution of E&M billing by level, by specialty, and see how that would impact different providers. And they said, there's going to be some disparate impacts here. And the situation I just described would happen. So they proposed to solve this inequity, if you will, by adding a specialty add-on code that they subsequently valued at around $14 that would apply to certain specialties where they felt it was appropriate, and also to create an add-on services code that was briefer than the current ones, and to pay. So if you had a patient that required 2 hours of E&M services, you had a mechanism for getting better reimbursement. Now, to add money to one bucket, then we have to take money from another CMS bucket, right? So they proposed initially reducing E&M payments on the same day as the procedure, considering they felt there might be significant overlap in the evaluation services included with that procedure. So the pricing mechanism and this offset mechanism immediately drew a lot of scrutiny. So here's, again, the initial proposal, and you can, you can see the specialties that were impacted. And so they proposed to create a G-code for visit complexity inherent to an E&M on the assumption that folks in these specialties tended to see sicker patients or more intense patients and required higher levels of service. So they were going to allow certain specialties to bill this add-on. Again, if you were especially impacted, you might like that. Others might not like that. So there was a lot of immediate feedback, positive and negative, about the proposal. Number one, I think a lot of feedback that, yeah, it's great, we're doing something finally. We've all been living with various issues for many, many years. So, and we've heard a lot from physicians about the fact that, again, the EHR and the records and the note. I practiced for many years in Central Texas at Scott and White Clinic, and I ran into one of my colleagues recently in FP. He works from 8 to 4 seeing patients, and then from 4 to 5, he does what he calls feeding the beast. He sits down and enters into the electronic medical record before he can go home. Others tend to do it at night, but it's real and it's out there. So CMS said, look, we can do something about this. So let's streamline the required documentation by only requiring documentation of history changes from the last visit. So we don't have to go back and say, yes, in 1984, someone had a surgery, right? It's already in the record somewhere. What's happened since the last visit? So eliminating the need to redocument from practice staff or patient. So again, if the information's there, it looks correct, you don't have to go back and ask the question again. And removing the need to home visits we talked about before. Now, the pushback across broad specialty societies and organized medicine was, do not do the collapsed payment rate and the add-on codes. There will be winners and losers. The dollars don't seem right. The calculations don't seem right. You'll put some perverse incentives into the system potentially. So this is not a good idea. There was particular pushback on reducing E&M services on the same day as procedures typically are accurately evaluated for whatever E&M services in that procedure on that day. And if you're doing some other service for that member, what would be the rationale for taking a 50% cut on that? And in general, the recommendation from organized medicine was, let's put your proposal aside. We thank you for getting things forward, and let's see what we can achieve as a unified group of stakeholders who's very interested in all of this. So CMS, in July, released this, and in response, the CPT process sprang into action. Drs. Brennan Sinovic and Dr. Smith from the RUC immediately, in coordination with the AMA, formed a work group. And this work group, which you can see the members up here and see the various specialty representatives, it was an attempt to balance membership both from the CPT Editorial Panel, the RUC, primary care specialties, and other types of specialties. So you can see the folks were there, a lot of folks here with a lot of experience and history in the field. I was one of those members as a family physician and representative of CPT. So the work group charge, now you have to understand this work group was formed on the fly at a time of year when many people are out of the country or doing other things. So we had many a call about, okay, so we're going to throw this thing together. What's it going to do? How are we going to structure it? How fast can we make it go? What are the barriers? What are we going to do with it? So the original intent was open-ended. Okay, the work group will be formed. We'll go out to all sorts of folks, specialty societies, others, and say, what should we be doing? What's the best coding solution? We've got a short time frame, but we've got a wonderful opportunity. And the goal from the get-go was to have an alternative out to CMS before final rulemaking occurred. And if you think about all of that, what that meant a lot of intense work, both in staff time and evaluating proposals, as well as just meeting time and hashing through different views. We thought at the time that if we could pull this off, that this would be a great way to validate the work that we all do through the CPT and the RUC panels. So we had 7 open calls and 1 face-to-face meeting to discuss issues. The open calls, the first time we did one, we had to wait while we added more lines. We ended up having over 300 people, various call-ins, on each call, which represented both specialty societies, payers from both government and commercial lines of business, and CMS staff. And we always had to be conscious of the fact that we never knew who was listening in on the call, including the administrator. So we had folks who were very interested in this process. We started the process out, and I give Peter and Barbara and Dr. Smith great credit for just being open-ended. Okay, what do we want to work on? Where do we want to go? So we did surveys. In some cases, we did closed voting. In other cases, we did open voting. And said, okay, do we go this way or do we go that way? What's the sense of the group? We would often debate the issues for 20, 30 minutes, an hour, and then revisit before we finally were able to move forward. We got from these surveys, for instance, from stakeholder organizations, 60 different responses that ranged from adopt the CMS proposal all the way. You can imagine that was a specialty that really liked the payment mechanism, to no, you can't do that, to you shouldn't be using CPT at all, you should be letting us craft our own, or you should issue G codes. So it was all over the map. So when we started looking at medical decision-making and time things, we tried to incorporate all that stakeholder input. Wasn't perfect and was an iterative process, but that was the value of having that information. So the guiding principles were established from the get-go, and this was very helpful. And I think Dr. Levy helped drive that. So we wanted to decrease administrative burden of documentation and coding. A very clear statement that was in alignment with CMS's proposal. We wanted to decrease the need for audits. No one likes audits, including the people that do them, all right? The people who pay for them, certainly. So if you can get a process that's more transparent, where you don't have to audit, where you're paying fairly for services rendered, we'd all be better off. We wanted to increase unnecessary documentation to get at that record bloat, and we wanted to ensure that the payment for the E&M service rendered is resource-based and was not the basis for redistribution of dollars across specialties. A little bit different than CMS's approach, which was, blend the rates and then try and account for specialty differences. Here we're saying, no, create appropriate codes that reflect the actual work done, regardless of who the physician is. So what did we do with each of those principles? So for decreasing administrative burden, we can remove scoring for the history and physical examination. As we talked about, we're no longer going to do this massive. We've moved to what's called a medically appropriate history and physical examination, medically appropriate at the time. So you're not having to go through for a 99214 or 5 and document this massive physical examination if it does not impact the need for care that day. So we can decrease the need for audits if we can have more consistent coding structure that's more easily transparent for folks, and that both parties who are being audited and doing the auditing can agree. To decrease the unnecessary documentation we talked about. And by using current medical decision-making criteria, we have already a lot of tools out there and a lot of education, which we think will help decrease debates about medical decision-making. Any questions on that before I go forward? Any comments from folks? All right. So we come to a summary of the revisions. Now, it's very important to know that through this process, we're talking about office visit codes that it will be effective in 2021. We're not talking about observation, we're not talking about hospital, we're not talking about ER. So we've got the 99201 through 05, the 99211 through 15. That's what we're talking about here, the changes. There are plans and to address other codes as we go forward, to think about that, and we're in ideation about that now. But this is the first code set that we're looking at. message delivered. So here's the summary of the revisions that we will all start to digest. Now we're putting out CPT assistant articles, we have parenthetical instructions, we have materials that'll go in the book, we have all sorts of ways of trying to educate and learn on the fly here. This will be an iterative process. We'll get some things wrong at first, and we need feedback from folks like who are in this room to tell us where things are working or not. So we've had a tremendous rewrite of the guideline with additions, revisions, and structuring. And think about it, you have to keep the guidelines in place for the old code set, and then you have to have the guides in place for the office set. So as we've gone through and written that, we've tried to clean up any of the cross-references and make sure we clearly identify which code set we're talking about at the time of the particular change. So one of the things we could do is survey the use of codes. And the 99201 code is very rarely used and was actually a fairly easy one for elimination. We did not seem to disadvantage anybody. They both required, both the 01 and 02 codes required straightforward medical decision making, so we really think there's very little risk in removing that code. We did decide to keep the 99211 because it does get a fair amount of utilization, particularly for nursing staff time, for brief pediatric things, so that's still around. The components for code selection now, think about it. Now we're looking at a medically appropriate history and or examination. All right, that's a given. You have to do that in your E&M service in the new world. You have to, then you have a choice. Then you can decide, okay, medical decision making is how I'm going to proceed for picking the code I want to report, or I can use total time on the date of the encounter. And this slide is kind of the crux of it all right here at a very high level. If you get this, the rest of it kind of follows. Medically appropriate history and examination required for anything. MDM, medical decision making, or total time on the date of service. Those are your options. So then, what does that mean? So for medical decision making, we've done a lot of clarifications to define the elements. We have tables to look at various aspects. We have case examples. These were, shall I say, robustly debated and may be subject to change over time also. Do they lend more complexity or less complexity? We hope they're clear enough that will actually make life simpler. Time. We're now talking about total time spent with the patient on the day of the encounter, including non-face-to-face time. So this is a big deal, all right? This is no longer, I spent 20 minutes in the exam room face-to-face with the patient. This is, okay, I did 15 minutes with the patient, I called the specialist for 5 minutes, I did this for another 5 minutes, some non-face-to-face time. Now we're talking total time. And particularly in the commercial space, I think my guess is we're going to see an impact on levels of coding as we go through that process. We've also tried to define clear time range for each code rather than defaulting to sometimes confusing CPT convention on midpoints of codes or 8 minutes or 15 minutes. So we took a very directed tactic to write explicit time ranges into the codes. We also, in keeping with CMS's suggestions, added a shorter 15-minute prolonged visit code, which can be used in those cases where you go beyond the highest level service, as defined in the new codes 05 or 15. So if you exceed that, and we'll look at the code so you can see what that looks like, then you have some way of reporting those additional E&M services. This is an addition. The other prolonged services codes we had were much longer time frames, but now we're talking about 15 minutes of additional time should result in more reporting and more compensation. So again, we're going to go through this in detail, so I'm not going to dive into this one, this detailed slide. This is a comparison between what we're doing in the office space codes versus the other codes. Things like this will be in educational materials and in the book, so the manual, so that you can actually see that and have a place to go. Okay, when can I use time, total time? When can I use total time? When is medical decision making, et cetera? So this is something we will all study and have by our desks, I think, as we go forward. All right, so what do the codes look like? So what's remarkable as we go through these codes, and we're not going to spend a lot of time on every slide, is look at the things that have been struck. So here we've deleted 99201. Here's your new 99202 code for 2021. So you have an office or other outpatient visit, evaluation and management of a new patient, which requires, boom, a medically appropriate history and/or examination and straightforward medical decision making. All right? We've eliminated all this about problem-focused history, all this about counseling coordination, and some of the typical patient times. That's all gone from that. So the code is simpler. We also put the disclaimer at the bottom or the note at the bottom. It says, when using time for code selection, 15 to 29 minutes of total time is spent on the date of the encounter. So you know now that if I saw the patient for 27 minutes and I'm reporting based on time, boom, this is the code I use. So we've tried to make that as explicit as possible. Now, when we get to the interactions with the other prolonged services codes, it may be a little more complicated. But our goal here was to really simplify what is in the descriptor so that most folks can understand it, even a layperson could understand this, I think. All right, so briefly, if you go through the other slides, you see the same structure for the other codes. Medical appropriate history and examination, and here we have a low level of medical decision making for 99203, and we have 30 to 44 minutes of time. So this is your new patient visit. For 04, again, now we have a moderate level of medical decision making and 45 to 59 minutes of time. So hopefully you're seeing the consistency in the structure here. And then for 05, we have a high level of medical decision making, as well as 60 to 74 minutes of total time. And then we have the note at the bottom that says if you're doing 75 minutes or longer, then you should see the prolonged services code, the 15-minute code that's been created. So that's our intent. Now, obviously, there's some border issues there, and we'll have to make sure we have tables and things that folks can understand where the break is exactly. And what does it mean to report 15 minutes? And we'll go into that in great detail. So if you look at the established codes, you're going to see the same type of structure. The 99211 was essentially left alone. We just removed the time issue on it. So I think it's useful to continue pretty much the way it has been currently. The 212, the office-based code now for an established patient, we again have a medically appropriate history and or examination and straightforward medical decision-making. And again, at the bottom, we have time now. Now, your times are different than your new patient because now this is an established patient. So here, we're using 10 to 19 minutes for the 99212. If you look at the 13, we see a low level of medical decision-making now is in there, consistent with the 03 code. And here we have 20 to 29 minutes. For the 14 code, We have moderate level of medical decision-making and 30 to 39 minutes. And again, we'll harp on it more later, total time, it's a different thing than face-to-face time with the physician in this construct. And 1.5, we have high levels of medical decision-making, 40 to 54 minutes, and beyond that, then you can use the prolonged services code. So let me stop there and invite feedback, questions, comments before we go forward. We've all been looking at this at this table ad nauseum since last summer, so we're very conversant with it now. And it's our child, and we like our child, but a lot of folks are going to be seeing this for the first time, and we need to know how to improve. So if you get comments today or in writing or pass them along, we're happy to hear them. All right, so we've done the related revisions in the parenthetical and guidelines as best we can. I'm sure we'll continue to wordsmith those.